So the whole idea for this forum is really supposed to be an OD directed discussion, and it's really, peer-to-peer education. If you were invited to this, it's because you've got a certain level of experience, and kind of like we've already been sort of talking informally, just trying to gain experience from each other and learning tips and tricks and pearls. And really, we wanted a forum. I mean, Ron and I, we started this a while ago about the idea of a little more off-label discussion. Things that RxSight can't necessarily say, but things that we can do in clinical practice, and how we really maximize this awesome technology. So today's discussion really is focused around the unhappy patient. So the patient, Jenny, that you were just talking about, patient like that, how do we avoid that scenario? Or the patient who maybe everything has been perfect, perfect 100% by the book, but they're still unhappy. So I guess kind of starting it off, I mean, how do we set the stage for people? I mean, for me, I hear this all the time, especially at like the refractive meetings. Happiness is the difference between reality and expectations. So setting the expectation, I think, at least in my practice, is so important. So how do you guys really talk to people about this? How do you explain that this is a journey? How do you explain kind of the give and the take in the optics? Nothing's perfect, right? So, I mean, Ron, why don't you kind of lead it off? What's your experience with that?
Yeah, I'm a big fan of letting them know that this is not a spectacle-free procedure. That the goal is to get them as independent from glasses as possible. Some people that can be all the time, but then that's great. But that's not going to be my spiel to the patient. That's not going to be my guarantee to the patient. I want to be really clear. I usually talk about these 4 different working distances, talk about driving, computer, cell phone, and reading. And I tell them that typically with this technology, we can hit driving, computer, and cell phone. And if you get reading, that's a benefit, that's a perk. But just mentally go in thinking that you will need some light readers. One of the things we did sort of recently, about, I don't know, it was maybe a month or 2 ago, we actually, in our consent form, we now have a section that's highlighted in yellow that they have to initial that says that they understand, with this LAL technology, that they may need reading glasses, for some activities. Because even with my conversation with patients, there are still times where people are like, "You said I would never have to wear glasses," and it's like, oh, no, that's bullshit, But so now we have them sign, because it's been a couple of patients where that's happened, where it's his word against mine, or whatever. So now I can just pull up the form and be like, "Are these your initials here?" So that's, I think, the main thing is, at least preoperatively, is to let them know that glasses are going to be needed for some activities.
Does anybody else have them sign things besides just the normal consent? I mean, anybody?
No, but we've seriously talked about it.
Yeah.
I'm glad to know somebody's doing that, because we're like, we have this, even on our descriptions, we have like smiley faces for distance, intermediate, computers, reading. And with the LAL, we kind of have this, like, it's not a smiley face, it's like straight across. It's like, reading's okay, but you might need some readers. And patients are like, I paid this money and I thought I was getting nothing. I'm going to be glasses free for the rest of my life. And we've actually had the conversation amongst us about, should we have them sign a form for the LAL saying you might need light readers for certain activities, especially for the moderate to high myopes, like our moderate myopes particularly. And I have a patient that I did not select the LAL for this patient, but I inherited her. She's a book editor.
Okay.
And she's been a toughie because she was a -7. And, she expects to be able to hold things like inches from her face. I'm like, no. I walked in the room, she goes, I can't read. And she's sitting there scrolling through her phone. I said, well, you're reading your text on your phone. Well, it's not effortless. I understand. So, but we've actually had the discussion about having them sign something about a light reader for the LAO, particularly the moderate myopes. So
Makes sense. I mean, what else would you do otherwise if you weren't going to do an LAL for that particular patient?
the only other thing is just a regular multifocal.
Okay.
Which I might have suggested for this particular person. But once again, personality assessment should have played in, and the person who did the pre-op didn't quite key in on that.
Gotcha. I see. In my experience, I mean, a multifocal, you're still probably going to need a light reader, especially for a book editor. If they're used to being
Correct.
here, I don't see a
Correct.
scenario. I mean, patients in our clinic, a lot of times, they think that they can just throw money at something and we can bend the laws of physics because of that.
Thank you for saying that. If I have enough money, I can make anything happen.
Yeah, sure. I mean, and I tell them you can keep paying me, and I have no incentive for you to be unhappy, but I can't.
Right.
It's that we're tied based on Newton's laws. This is all optics, so we got to work within the confines of what's practical, what's capable.
One thing I like to do at the first visit and then repeat at the next ones, just so that we're on the same page, is find out what their top 3 visual goals would be. Like, what do you do a lot? Are you outdoors pretty much all day? Do you like that book, or do you read books all day? So like, then you can just reference back, okay, these are our main goals, because you'll find that once you start giving them good vision, then they'll nitpick on the tiny things. Like, I cannot see the writing on this pill bottle. Okay, well, we already talked about this. Most of your day is spent, teaching Zoom calls or, playing with your grandkids. Let's think about how often you're looking at that pill bottle. And then like, once you kind of get them back on track, I think that will help them focus more on the positive instead of like, because, just like for us, the worst patient outcomes always stick in our heads, and they're the ones that keep popping up. But think of all the happy patients we have. That's
Correct.
The same thing with our patients too, is like, they're just going to hang on to that tiny thing that they can't read. But if we can help remind them what they spend the majority of their day on, I think that kind of helps them appreciate what we've given them a little bit easier.
Does anybody start talking about targeting before surgery even happens? You start talking about refractive targeting. I mean, we know that at least for our patients, more than 90% of them are going to have some sort of blended vision. But we don't really get into details, but we do. Obviously, we do at LDD number 1. Does anybody, like Jessica, do you do that? Or
yeah, so at the console, I'll always go through it, like if they want as much glasses independence as possible, and my goal for them is like a mini mono vision or blended, we call it blended vision for patients. I will go into that a little bit, the cataract consult, because I don't want them to get to the adjustment process and then we're talking about how blended vision works, and then they get nervous. And so basically how I explain it is I'll just say, with this implant, in order to give most glasses independence as possible, we do something called a blended vision. I was like, this is not monovision, but we do make your dominant eye more distance focused and your non-dominant eye, more intermediate near focus. I was like, you won't notice anything as long as you don't cover up one eye. And I was like, no one walks around, with open. So I just
tell them I will yell at you if you do that.
Right. Yeah. And I just reassure them that everybody adapts to it. I've never had any issues with anyone not adapting to it. But I think if you don't educate on that at some point, I mean, I guess you could at the adjustment process, but I like to do it on the forefront. It just gives them an idea if they were to accidentally cover one eye or something, they wouldn't be nervous about what's going on. Did something happen with the treatments? And they'll understand how the process works a little bit more.
Yeah,
And
I'll even tell them,
yeah,
we're not going to make your eyes matchy, so don't do this.
Yeah, no.
Does everybody else do the same thing, where you talk about it before? I guess along that same line, does everybody here as an optometrist meet or have a touch point with these patients before surgery? Everybody does. Okay.
Yeah.
Yes, we try to.
Yeah. I know, Jenny, you're a little bit unique, probably not so much, but
A few
Um,
telehealth calls, but most of them first time at their first LED treatment.
yeah. And I think your surgeons that you work with are probably pretty well educated on the process at this point.
Yes,
I
yeah,
mean, if
so
they're
they do plant that seed ahead of time, so everyone kind of knows it's going to be a little bit blended.
Yeah. So I noticed I have one surgeon I work with, and he tends to be pretty optimistic to our patients, and as a lot of surgeons are. And I wasn't meeting the patients until they were in my chair for LDD number one, and it's a lot of, wait a sec, you're telling me I'm going to have to wear readers? What are you talking about? He said I didn't have to do that at all, and there's a lot of, so now we kind of play good cop, bad cop. You know, he's a good cop, and then I come in and I will have a touch point with every single one of these patients before surgery just to explain maybe a little bit more of the realistic goals and kind of how things go. But I think that it really helps because our patients now get two opinions, really. They're getting two perspectives and two points of view. Plus, they're dealing with me during the light treatments anyway, so I think there's benefit there. How do you guys determine eye dominance? It's not a real perfect science, I don't think. Does anybody have any techniques that they like to use to determine which eye they want their dominant eye to be?
Well, I'm in Texas. I ask them if they shoot.
Yeah, that's what we do in Wisconsin too.
Yeah, same for here.
We do
I do the blur test with the 150, and then I do it with behind them in the phoropter, and then also with loose lenses too, when they have the 8 well in front of them, just to see which one they can tolerate the reading over.
Okay.
I
Ron,
just
what
do
you
the fashion big E triangle.
Yeah.
I'll do the triangle. Do the hand.
So what do you, I got a question though. What do you do? Because some people are, I know for myself, I'm right eye dominant, but I shoot lefty, So what do you do? I'm kind of ambidextrous. So what do you do with somebody like me, who's kind of mentally confused?
I'm the same way. I'm super right-handed, but my left eye is by far my dominant. I trial frame. I mean, I trial frame in the clinic with options, and I have them walk around. I mean, take a walk. Do you feel like you're gonna throw up, or you feel comfortable?
Yeah,
Have you guys done
frame
the +75?
Yeah, yeah. Usually, I just enough to really sacrifice one eye a little bit. Not necessarily picking the target at that point as much as I would be just illustrating what it's like to have one eye worse than the other.
Do you ever consider holding 2 lenses just to show them, like some patients just can't even tolerate 150. So if we know that going ahead of time, then you can start kind of steering them in the right direction, that you're like, well, if we want to maintain that distance vision, just know that we're not going to be able to dial in as much reading as we initially anticipated, just so they're not so disappointed later on.
Yeah.
Something to save time, because this,
So
I think if they know more,
Go ahead. Sorry, go ahead, Jenny.
So I think if they kind of have a better idea of what the final long-term goal is, then they're less likely to be disappointed later on. So if you can just show them, all right, this is the amount you can tolerate, but notice how when you flip over, like, so I'll hold either a +75 versus 125 over their non-dominant. If the 125 already starts blurring or they feel nauseous, then you can already set the stage. You're like, all right, see what happens to your vision. This doesn't feel that great. We'll try to slowly dial you up to that, but just based off of these initial findings, you're probably not going to tolerate that much reading. And I think that'll help kind of cushion the blow a little bit if they need some light readers later on, because you told them right off the bat that, and they can see it. I think by seeing what happens to their distance vision, that helps them wrap their mind around it a little easier.
What about, has anybody had a patient where, because the first light treatment, you have the ability to add the depth of focus, the added spherical aberration, and you can't undo that. So has anybody had a patient who didn't tolerate it and you tried to undo it? And did it work? Jenny, you're nodding. Have you? Okay.
So I've had at least 8 so far. 1, but then soon to be 2. We got them back to Plano, but they still had that ghosting, shadowing in the distance, and it was just unbearable. So they had an explant. The first one we've already done, explanted, and got another LAL, targeted Plano. He's very happy with it. Okay. Second one is scheduled to the 13th.
Gotcha.
determined.
Wow.
Anybody else have that?
I
Yeah,
have one in my chair today, and
Okay.
we're trying some different stuff. This happens to be a patient with a hyperphoria, and unbeknownst, she had worn Prism in the past. So I'm actually going to try some Prism with her first before we talk about some sort of explant or something, because she's plano in both eyes now, but she still has ghosting. But she's got this little bit of right hyper, and I'm going to try the Prism first.
Mhm.
It's a good strategy. Yeah.
Fingers crossed.
Yeah. We've had one early. I mean, this was probably early on, maybe 2021. We did have an explant where it was the same thing where she just didn't tolerate it, not as much as she confidently thought she could. And we ended up doing an explant for an LAL and then did just bilateral plano. So usually with those cases too, with that one case, I guess in my experience, we went into it knowing we were just doing a plano target. It was strictly, you didn't tolerate anything. We're not going to try to flip the eyes. We're just going plano. So if we're going to do this, there is no decision making anymore as a patient. It is plano 100%.
I got a question, kind of along this vein in that, have you guys had, I have two patients now that if you look at them on paper, they look absolutely perfect. They're 2015, and I'm not talking about, is it like COA, they're struggling. I'm talking like OHPNTZ. It's just rattle it off. And their near acuities J2, and they're absolutely miserable. And I mean, like in tears. The one lady's like, if I have to live like this, this is can't believe I spent, this kind of money, and I'm my vision's like this. And I show her, again, you guys know, we have the eye trace, I show her pre-op aberrations of her from her lens. And I mean, she's a 10, just, I mean, it would be somebody you would present, it's like such a perfect result. And yet she is really unhappy. And the only thing I can think of is that she's got some type of, super sensitivity to the blended vision. She does feel things are a little bit better if we correct her non-dominant eye and make it distant, but then she's all upset because she's like, why don't I just have regular cataract surgery if I have to wear reading glasses type thing? So does anybody, I guess my question is, with this anisometropia or anisoconia, whatever you want to call it. I mean, I know that some people can be super sensitive to small differences in their refractive error and image size. Any thoughts on that? Any way to test it preoperatively? Because the other guy's the same. I mean, he is really just spot on, and he was like 2060 preoperatively, and here he is an easy 2015, and he's unhappy. And I just don't know what to tell him. I don't know. We've talked about doing PRK on the non-dominant eye and then reimbursing them, for that particular eye for the LAL.
Have you tried any contact lenses yet, just so they can kind of stimulate some of it to see?
Yeah,
maybe
yeah.
you don't have to give them all the way to plano.
Yeah, and we tried at first. I just tried to get them, their distance. I think she was a -1.25, and in her dominant eye, she was either plano or -1/4. So at first, I just gave her a little bit a -50 in her non-dominant eye, just to kind of cut a little bit of the aniso, thinking maybe she can't tolerate a $1.25, and let's give her 75. She said it helped, but then again, she said her near vision wasn't not acceptable. And so then I just tried the whole thing. And, we just made her some glasses that she could, when she's inside her house, she's fine. But when she drives, she feels like she can't see anything. When she's outdoors where she's looking at, optical infinity, she's miserable. And so any thoughts, or have you guys had this type of experience where on paper, they just look beautiful, but yet they're not a happy camper?
Yeah, I have a few times. Go ahead, Jess.
Okay. Yeah. I can think of a couple cases as well too. And I think one case, the patient was same way, 2015, like J2, said she couldn't even see her food. She was distraught.
Yeah.
And I found, like looking more deeper into her chart, she was nearsighted, prior to cataract surgery, and she was one of those patients that could hold things real close, see the really small detail. So even though she's seeing J2, she's used to seeing like J1 plus right here. So that was the first patient I figured out that just the near vision was never going to be the same it was, prior to cataract surgery. I had to just explain those expectations. And then the other time, was a patient, same way, but like they were a low myope or, not significantly myopic prior to cataract surgery, but they were a younger patient. They were in their 50s. So I think they had some, like, they were presbyopic, but still had a little bit of some accommodation prior to cataract surgery, and just lost that accommodation completely after the surgery. And with that patient, I gave them more time and followed up probably like a month or two. I think I gave them like 2 months, followed up 2 months later, and they were doing a little bit better. So I don't know how long it's been since the adjustment process, but you giving it more time could help a little bit too.
Yeah, we really postponed because she was fearful of locking in because, she wasn't happy. And I mean, her surgery, I think I just saw her about 2 weeks ago, and her surgery was in June. So she's already been out about 4 months or so. She just was fearful, like, because she just kept saying, if this is what we treated her aggressively for dry eye. I mean, everything, steroids, MIBO, whatever, tears.
How did she tolerate the distance glasses? Like, could we focus on, okay, 70% of your day is glasses free, but just when you need to drive and, see things.
Yeah, it's a great point, Jenny. That's what I tried to explain to her. I'm like, look,
She's like,
no. You're happy in your house. I mean, how many hours a day do you spend driving versus hanging out in a more closed environment? But she just feels that she just spent all this money, and her expectation, and I told her, I said, I just think your expectation was not realistic. And, we talked about having to wear glasses for some things, but I mean, she's a grandmother, just became a grandmother, and she's like, I can't even see the baby's face. And she starts bawling, and I'm like, oh my God, it's just, how can you not see a face? But yeah, so trust me, I'm trying to dwell on the positive with her, and just let her know that you drive, maybe 30, 60 minutes a day, but she claims it's when she's outdoors in general. If she's at a store, if she's walking around her block, she just feels that things are just horrible, so it's really frustrating because obviously we want them to be happy, and she seems to be, we hit our targets and everything looks great, but it's not.
I have a thought. I haven't had that exactly. I had a multifocal patient like that. She couldn't walk into a big box store or anything. She just, like, all of a sudden, I just can't see. I actually sent her to a colleague who does visual perceptual and that kind of stuff. And he put her in binasal occlusion. And it helped her. She could now go into stores and stuff. Maybe it's not the LAL doing it. Maybe because this was a patient who was okay for a while and then developed this as an older person. I'm wondering if maybe she has a visual perceptual issue that a neurooptometrist might be able to help with. I don't have an LAL patient I've done this with, but I had a multifocal patient that we did this with, and she's much better. But it wasn't the lenses that we put in her eyes.
So, hey everyone. Just a quick question. Just a question based off of Nick, or like what you initially said about adding spherical aberrations. How often are you guys adding spherical aberrations to the dominant eye while you're targeting them to plano? Do you do that a lot, or is it only for certain patients? Like, how often do you do it?
I don't do it at all. I leave the dominant eye assuming, actually, I think always, even if I'm doing a bilateral myopic target, which I do on occasion for certain patients, I usually leave the dominant eye still targeted for plano at the first treatment to avoid the added depth of focus, just in case? Jenny, you were shaking your head too.
Yes, because if you do that, they're going to have shadowing when they read, which you don't want that. You want nice, crisp. So if you want crisp vision, you can't induce any of that eat off on that first treatment. But that's not to say, like Nick said, do it on the second, third, or fourth, just not on the first one.
Mm-hmm. Back on, hey Ron, your patient you're talking about, did that patient notice problems after the lock-in? Or was it, or you said you hadn't gone to lock-in?
No, I did, because this had gone on for 4 months and
Okay.
tried all these variations and nothing was working. So finally I just said, we're gonna lock you in, and if you have to wear glasses, that's kind of where we are right now. Is she's got glasses for driving and that kind of thing.
So it was present before lock-in. Did anybody notice problems after the lock-in?
I've had a couple patients now that they were killing it, and then we do the first lock-in and they're mad. Just something changes, and it's not even that their prescription is changing, it's just they're not appreciating it as much. And when I talked to RxSight, they had said, okay, like a half diopter change into hyperopia maybe is normal, and then the second lock-in should put it back. So I'm trying to convince these people, like, okay, we have to do the second one, and like hoping that it fixes it. But I've had 2 explants now because of this reason.
Yeah,
go ahead.
No, sorry. I was just about to add to her. Is it like I've had 2 patients actually today. I got my second patient who had a complaint regarding the fact that they were able to see very well before the first lock-in, and then after the second lock-in, they're just not able to see well. And I was like, oh, it's okay. You know what? Let's do this. Sorry, after the first lock-in, they're not able to see well. Then I'm like, let's do the second lock-in, because it should technically cause a neutral change and might just actually like reverse it back. Then I got the 1 month report from their own like optometrist, and refraction was coming up to minus 0.25 with minus 50 still. And in my initial lock-in was plano. So I'm like, okay, so this, so it actually went on to the myopic side, and not just a little, but to like a decent amount.
Yeah, I had a guy who went, he was super happy after lock-in 1, all was good, lock-in 2. And Nick, you and I think Nick talked about this guy where he ended up being like a minus 75 and was super unhappy. And I let him go for about 3 months. We gave him a contact lens, couple of trials. And it was still several months later, he was still at a 75. We ultimately PRK'd him, and he was happy, but he definitely noticed, and it did show in his refraction that he had a 0.75 shift.
I've had a couple, not many. Again, I think we're picking just a few people when there's hundreds that have not had this, but there's been a few where even refractively after the second lock, they're relatively still plano, but it's just a perceivably subjective difference in the quality of vision. They're still 20/20, they're still 20/15, but it's just not as easy. And something, I think part of it is definitely just the intensity of the light. And so I tell them, I warn them during the second lock, and hey, you're going to notice that your vision's probably worse tomorrow than it is right now. And that's just your cornea sort of reacting to all the UV energy. But I do wonder if something happens with the lens itself that we don't quite understand yet. And there's 1 or 2 that we have explanted because of that. They just can't put their finger on exactly what it is, but it's just not good quality vision. And we have a pretty high caliber aberrometer too that we use, and nothing's quantifiable, but we don't have an answer for it. And we've triaged it with RxSight. There's just no answer. And we've explanted and we've redone it. In one of the cases, we just redid the LAO and it was better. So I don't know if anybody else had that sort of issue. But again, for us, it's been like 2 out of like almost 1,000. But they're the ones that you remember.
Yeah, exactly.
They're the ones you remember. Anybody else have any comments on that?
I had 1 out of the hundreds we've done that after the first lock-in noticed a change. I had a And I picked a little something up on the refraction, and I went a little cowboy, and I said, hey, before we do the second lock-in, let's just do a little treatment, because it was like, we're talking like just this little bit. And we just did a treatment, and I don't know if it was placebo effect or not, but then he was happy. We were able to lock in the second one. He had a little myopic shift. We were able to do the second lock-in after a treatment in between. I'm not saying this is, I would prescribe or suggest doing this, but this patient ended up happy and he has not come back. So
We've done the same thing, actually. I have one patient where she went myopic on the first, and we did a treatment, and it budged, like, honestly, like maybe 50, like it went 50 less
yeah,
myopic.
I don't even
and
know if
she
I got
was,
50.
yeah, and she was like over the moon.
Yep.
So maybe it was
That was this
placebo.
guy. I'm like, okay.
So you did a treatment in between the lock-ins, right? That's what I understand.
Yeah, so we
Yes.
created like a burner account essentially
Okay.
for them, and then
Yes.
just did that way.
I've never done
Yes.
that, but because it's a good idea. I never really thought about doing that, because I've had a couple patients too where they have been a little bit more myopic than expected, but we just proceed with the final lock-in no matter what.
I'll be
Assuming,
honest, I don't know,
yeah.
for me, it's like, we're talking a quarter here. Was it refraction? Was it placebo effect? But the
Sure.
patient was happy. And I'm like,
That's
okay.
key. Did you wait between and like just make sure that MR was repeatable before? Okay, good. And
Yes,
how long
yes.
did you wait in between? Because I think that's a great idea. Like patient is happy.
Maybe a
That's
week or so.
a week.
Yeah, we
Okay.
did a week for ours too.
Perfect.
Yeah, I think that's a
I
great
actually
idea.
have a question. Do y'all ever go right to lock-in? Like do like a burner treatment because they're happy, and then you go right to lock-in?
I actually have an anecdote about that exact. I was going to bring that up because Jenny and you and I have talked about that, about
Mhm.
doing that, and I used to do that routinely because my theory, right, is that you want to avoid exposure to the cornea because it's just going to make the patient unhappy if you're not really doing anything. It's just going to feel scratchy and gritty. So, yeah, burn it into thin air and then just go to lock-in.
Mhm.
I had a lady that I saw not long ago where she was really high in your demand. She was a nurse, she does sutures, she wanted to be independent. This is another one of those ones where her expectations were just out of control. But really, she valued the ability to do sutures. And I did exactly that. She was playing on the one eye. She was -1.25 or so. I don't remember what we ended up targeting, the non-dominant eye, but she was happy. Less than thrilled because she still had to wear reading glasses. But she still had 20/15 in the dominant eye. And I saw her back for her, we usually do about a 1 month post-lock visit just to check numbers and make sure everything looks good. And she was -75. She had shifted a very crisp -75, and she noted it. She's like, I'm happy, but I'm not. I can see my sutures so well, way better than you said I was going to, but now distance is blurry. And I contacted RxSight, and they informed me that actually the first treatment is part of the calculated finite number of macromers. So they advised not to do that. And that was why. So yeah, so she was okay. I mean, she's now -75, but she wasn't that mad about it. So I think I kind of
We've
fell
done
into.
it. Yeah. The one time we did it,
Mhm.
that's the one and only time, because it completely burned us. Like we ended up she ended up like a -2, and I think we were aiming for like she was a -1, she ended up -2, even though we put in the -1, and then we weren't able to get her back. So from that moment on, I was like, I'm never doing this again. I'll just do a basic one with the patient's eye and then move on.
Yeah, I've never done just burn it off. I've done, Plano, just their Plano, target Plano or something, but I do a treatment and then we lock them in the next time.
Mhm.
I may not change anything, but the machine will run and it will do that. And we were great. The patient was happy.
Yeah,
Yeah.
I've had no issue doing it that way before. I just trying to avoid exposure if I can. And yeah, apparently it is a part of the calculation. So you are technically supposed to. But I had done that before in the past with no issue. So it was just this
Okay.
one time, and that last time, yeah. But Jenny, I know
Yeah.
you do that pretty routinely, right? So you haven't experienced any problems with that?
Yeah, I haven't experienced any problems.
That's great.
Good.
But yes, but I'm weary because it is in the nomenclature. So I always encourage other doctors, don't do it. Like just because once the patient's stuck, then yeah.
Yeah.
But so don't follow my lead on that one at all.
That's good to know. I mean, it's good to know that it's not 100%. Like I said, I fell into a happy mistake, I think. But I'm aware that, yeah, okay. But that's just my experience. Let's see. Anybody else have anything they want to talk about there, like on the unhappy patient in particular? Like how to deal with these people? So I guess I was kind of hinting to Jenny and Ron and Jess before. I had an anecdote of a patient I saw just yesterday. How do you explain to the individual who just doesn't seem like they're getting it? So, for instance, this lady, she had seen my surgeon, she had seen me. We had the discussion, all the normal stuff that we do, outline what we were going to do, and we got to the point of her first light treatment, and I beat the horse so dead. We're going to target your right eye for distance, your left eye for reading. I did trial frames and everything. And we got to being in front of the machine. We're like in our little closeted dark room. And I just confirmed, right? Okay, right eye distance, left eye for reading. And she looked at me like it was the first time I ever said any of those words. And she's like, what are you talking about? I don't want that. I want my other eye for distance. And well, it was questioning my own sanity. Like, who was I talking to? Was I just talking to myself? Okay. So how would you guys handle that situation where clearly there's a miscommunication, no matter how good I think that I did it or how properly I think I explained it? This patient didn't get it, and we were clearly on different wavelengths.
I'll comment on that because I just had
Yeah.
this scenario where I had this woman who she was doing very well. We were ready to lock her in, and she was really upset that her left eye, her non-dominant eye, was blurred far away. And I was like, Arlene, we've talked about this, for I can't tell you how many conversations that, the right eye is going to be your distant dominant, your left eye is going to be your near. So yes, if you do this, you're going to notice a difference in the distance where the left eye is going to be blurred. And if you do that for up close, the right eye is going to be blurred. She could not accept, that when she did this, her left eye was blurred in the distance. So I said, okay, let's just try this. And then you go home for a few days and you tell me if you like it. And I put a contact lens on her left eye that made her see far away, said goodbye. And she left, and I get a phone call like 2 days later, like, I can't see close, and I'm like, exactly. This is what we're talking about. Your left eye stop. Do you like it that way? I can make it that way. And she was like, absolutely not. And then she came back and we locked her in and, took the lens out and whatever. So that's how we handle that. Is I just said, okay.
Yeah, I think contacts are a good option for patients, like to show them before you waste a treatment on them. Right. Because you could talk until your face is blue, and I don't think she's going to get it until she sees it for in the real world.
I just had a patient today tell me, well, my regular optometrist told me that I should have my left eye for reading. Mind you, I've seen her 4 times. We're on second or third treatment. She goes, well, my eye doctor said, well, I'm going to put it in my notes that my left eye needs to be for reading. I'm like, but your left eye is your dominant eye. And if I do that, you can't drive a car. And I said, now, wait a minute. And I went back. I said, I have nothing in the notes from your eye doctor that says that. But in her mind, she was saying, I'm pretty sure we should reverse this. She was just worried because when I had to set off the spherical aberration in her non-dominant eye, I had to kind of really be aggressive. And I told her, I said, you might not like my first treatment, but then I'm going to bring it back because she had some cylinder I had to correct for as well. So to get both meridians minus a half, I had to take her further than I wanted to. And I brought her back and it's made her better. But in her mind, she was saying, but my doctor said this. I'm like, no, they didn't. And I said, if we reverse that, so if she comes back next week, I'm going to try a contact lens on her because that's a great idea.
Just show them with a contact.
Yeah. I use it on a lot of these patients. I will put a contact lens on them. Absolutely.
I guess the I would say the best part about the contact lenses is that you let them tell you what they want after they experience it, and then it becomes their idea. So it's like, okay, here, I'll put the contact lens on, right? Now you can just take a look and see how it is. Is it better with reading? Is it better for distance? And they're like, oh, yes, I like this. Perfect. I'll do exactly what you want me to do. And that really just sets the pace. It makes them feel like they're kind of dictating what they actually really want, but it's basically what I really want them to have.
Yeah, I think that's a good strategy though. I mean, you want the patient to really feel like this is their idea. And it's that sense of control, which is like the whole beauty in this whole process, is they have the control in this, where you're really pulling the strings, but they get that sense of control. So for this lady that I was talking about, we were in front, she was fully dilated, and I said, nope, we're not doing anything. You're gonna go home, we're gonna think about this. And she came back and she was kind of aggressive. And this was when I had my new tech who was there kind of observing. And she sensed this interaction going very south really quick. I told her, like, leave, get out of the room. But we kind of circled back. I was like, okay, this is the world of refractive surgery. You're going to have patients who seem lovely. She's a nice, 7-year-old grandma with a bunch of grandkids. Yeah, she's still kind of a pain. So you're going to see that. But then we circled back a week later, and the patient understood. I think time was the best thing that healed everything. She totally understood. She's like, I'm sorry, I came off kind of rough, and I understand what you're trying to do. And yeah, thank you. I'm trying to help you. I'm not here to. I don't have any incentive for you to be unhappy. So,
hey Nick, can I know just sort of off topic, but I know we have several new doctors on the call. Yeah. Should we maybe just leave a few minutes at the end or whenever to see if they have any questions, as they're getting started, with the LDD and LALs, and just give them a couple minutes of the floor to see if there's something that's they're wanting to have answered, before this session ends.
Yeah, I think right now is a good time. I mean, we've got about 15 minutes left. Does anybody, any of the newcomers who haven't joined us before, who maybe are just getting started, does anybody have any questions or comments or anything? This is an open forum. There's no formal agenda here.
Yeah, this is Howell Findlay. I have a question. I'm pretty much a novice, a newbie here. So is there any website or lecture or something that tells me how to start off? Like when, you're what do you target? If you're going to go by both eyes distance, what do you target? If you're going to do a blended, do you target a non-dominant for -75, and those sorts of things. And I also was wondering in your earlier discussions about doing another adjustment between the lock-ins, had you already used up, did you have adjustments to use, or had you already done 3 adjustments and then lock in? So basic things like, what's the time frame on when do you do your first lock-in? Is it 3 weeks? I mean, that's what we've been doing, is 3 weeks. But when do you do your second adjustment? I'm sorry, your adjustment. The timing on those things. I need some real basic information.
Yeah. So I think you asked about a website. I think eventually this is our third session that we're doing right now. They're recorded. I can send you the previous 2, Howard, if you want, to kind of sit in on them. We're probably going to start. We have a domain, RxInsights.com. I think we're going to probably throw those on there too at some point. As far as, at least for us, and I think everybody here, at least, Ron, Jenny, Karen, and Jess, we're all pretty much on the same timeline. Usually it's week 3, we start with treatment, sometimes 1 month, depending on certain scenarios. I think
sooner than 17 days. We did that when it first launched, and you'll have regression in the future then. So you want to ideally wait 21 days, and that their MR is going to be more stable.
Great.
Also, I don't know if you've heard about the LAL roundtables, but those are really good too. Those are through RxSight, so they're not off-label like these discussions, but they actually go through some of the targeting as well, and more of the basics, and starting a clinic and all those type of things that I'm sure we could send you a link to.
And
Great.
RxSight has a new basic library that has all our videos and things like that in there, so you can kind of search for what you're looking for. And there's a bunch of videos that like short ones that you can kind of watch or listen to.
Excellent. Thank you.
And did you have a representative to come to your clinic when you were initially starting this?
We did, but I think at that time, I think Dr. Patel was doing most of the work with them. I didn't get to spend a lot of time with them.
Okay, they will come back out and work with you as well. The reps are very flexible as far as that goes. If you want somebody to come out hands-on as well, because our rep has come back a couple times because we've added new doctors to our office since we started, and they're now doing LALs. So I actually had our rep come back out to work with the new docs while I was in clinic, and it was very helpful because they got the same startup I did, and that helped a lot for them.
Great. Thank you.
And the Dr. King thing is, for me, I always have everybody test drive the vision at least 1 week between treatments so that they can do professional, business type vision and leisure vision weekdays and weekends before they make any judgments on the adjustments we did, to the point that you asked earlier.
Right. Thank you.
It was a pearl I picked from this group here because we were doing them previously per the FDA trial, 17 days, then 3 days in between. But you're right. I think, Ken, you mentioned that your life on a Tuesday is different than your life on a Saturday.
Correct.
And I had patients who totally appreciated that. Like, yeah, I don't really know because I haven't been to the lake yet. I haven't been out on the golf course yet because I'm doing that on Sunday. So yeah, we get them 1 week at least. But I think certain circumstances too, we extend it out. I mean, the thing that I always preach to these patients is time is our best friend. If there's
Absolutely.
any sort of hesitation, I'm there no matter what. It's their journey. If they want to add on another week to test drive it, we can do that.
Yep.
Now, like Ron, you mentioned before, I think the active shield does wear off over a certain time. So there is like a finite date that we want to be done, but it can be months. It doesn't have to be, we don't have to get it done quick, but we don't want to send it out a year, 6 months. I mean, really, I think 6 months is probably pushing it, but.
Yeah, I think sometimes, we get, or at least initially when I started doing these, I felt pressured like to get this thing done as quickly as possible. So they're out of their UV glasses and what have you. But I've learned over time that, as you said, Nick, time is our friend, that when in doubt, don't do anything, just postpone, give them a few more days or another week or something, just to go live with it for a little longer, kind of figure out what they want to do. And I think that's the best thing, is don't be forced or rushed into anything. If there's some confusion as to, how the patient's happiness level is, I would postpone.
So to that, the very first time when I see the patient, when they're ready for their adjustment and they're super excited, I tell them immediately, it's like, I'm about to pop your bubble. Okay. Expect yourself to go home without any adjustments. If I'm noticing that the numbers are just not matching and the vision is just not right, if I'm seeing dryness, like, I'm sending you home, and I'm sending you home for your benefit. And I tell them, like, patients that I tend to delay, or patients that have been delayed, they end up getting really good results. Is because we're letting the eyes to recover. We're taking our time. You're trying out your vision a bit more. And so usually in my very first appointment with them, I set the pace and I tell them that, listen, this is not a race, this is a marathon, and we're doing something that you're going to benefit from for the rest of your life, rather than just immediately right now. So if there's a delay, it's not a big problem, right? And it's only for your benefit.
Yeah, and I think patients really respect that too, coming from the doctor, that you're telling them too that, I care so much about the accuracy of this refraction that I want to be absolutely sure we only have so many adjustments. Let's give it more time. No patient's ever going to be like, no, I want you to treat me now. You don't have a
Nope, they won't do that.
That surprised me though, because when I started doing this a couple of years ago, I thought that everybody's going to want to get done with this process so quick. But I could have been more wrong. I mean, everybody, I want more time. Okay, that's fine.
Yeah.
Take as much time as you want. That's totally fine. Anybody else? Anybody else have any questions or comments or anything they want to talk about?
I do have a couple questions.
Yeah.
Sorry, on the beginning, I'm in California, so I was driving home from work, all that kind of stuff. Quick question for, I guess, the majority of the group. Are you guys charging for your trial contact lenses when you're testing out the monovision?
No.
Here at UCSF, like I work at UCSF, and it's, you know, I've talked to providers, and like, so for example, if I'm trialing monovision for like PRK or LASIK, then we'll like discount it from their procedure. Otherwise we're billing them. But in terms of like after like the post-operative, kind of, we're obviously not collecting any more money. So you guys just kind of letting them take as many contact lenses as they need, or like, how are you guys doing that?
Yeah, if you start doing a la carte, I think they're going to get upset that they're being nickeled and dimed for everything. They're already investing, you know, $8,000, and so trial lenses don't cost me a dime. You know, we just give them to them for free.
Yeah. And the thing with me is like, I get a little bit of pushback from like, kind of management, because like you said, the trial lenses don't cost, but at the same time, I think, you have to hit like a certain number of, like selling like contact lenses in order to get a certain amount of trial lenses, if I'm not mistaken. So I don't really know in terms of, like, I personally am not doing it for the L, but in general, like, is it done? Are you guys doing it? But it makes sense not to.
I mean, when we used to do like the restores and Panoptics, if we up their price, if you're feeling that you need to charge for that, we up their price to, on the rare event that somebody needed a PRK enhancement. We don't have our own laser, so we would have to pay a facility fee, surgeon fee for that. So in order to absorb that cost, instead of telling them, oh, you spent this money and now you're going to spend another $1,000 for PRK for both eyes, we ended up just upping it a couple $100, and that if they needed PRK, it was no cost. So
Right.
if you're getting pushed back by management, I would consider raising your price a little bit, and that would absorb any kind of trial lens cost.
Thanks. That's helpful.
You guys, do you do that?
I don't
so
have
like,
contact
a
lenses
question based
available.
off-
Yeah. Which say?
Sorry, so like I just have a question based off of that. The type of trial lenses that you provide, do you provide a daily lens, or is this like a monthly lens that they can basically try on for the entire week? And if it is a monthly lens that they're trying on for a week, do you provide any sort of like topical like antibiotic coverage?
No, we give them a lens, some tears. We put it in their eye because some of them have never worn contacts. If they're inexperienced, we put it in. They'll wear it for 3 or 4 days and come back, and we'll take it out.
Yeah, I have both daily and monthly. So if they were previous contact lens wearers, I'll give them dailies. And then if they're not, we'll put it in, we'll take it out. Same thing. And we don't even fit contacts in our practice. So I have an account with J&J. I order a bunch of trials. I just have them sitting in my office. It costs me $6.95 to ship the trials to me, and I can get as many as I want. They don't ding me or anything. I order them straight from them, and I just grab them off the shelf and give them to the patient.
For the trial, because we don't have contact lenses either. Do you have specific power? Are you just like looking at +1s? I mean, if I were to get contact like a single box of X power, what would you recommend? Like a +1, a +1.5?
I
I
just
actually
ordered.
keep a range.
Me too. My
Yeah.
like -150 up to +150 in 50 increments, because like
Yep.
like Ken said, you
What
can
I
get
do.
the trials for free and just keep them in the back. The expiration is about what, 2-3 years. So
Yep.
the last doesn't cost you anything except shipping. And I think the shipping is well worth it just to have that on file. So you could just hand them. And I try to get the dailies just so that they can change it, or else you might not, if you want to put them in for the patient and let them wear it for a day or two and just make sure they keep lubricating.
I started keeping a few monthlies around too, just for the patients that couldn't put them in and out. We also do ICLs and stuff in our office, so I have to do contact lens over refractions. So I ended up keeping a range of these in there anyway, so I have a little broader range. But for the LALs, a -150 to a +150, you're covered.
Yeah, that's good.
Yeah, just get some more of the +50s and +75s, because I feel like those are the ones that you're gonna go through them the most.
They're the most common.
Good advice. Good advice. Anybody else have any? We're coming up on about an hour. Any other comments, questions? Cool. I think we'll do another one probably. Yeah, go ahead, Lou.
Oh, I just wanted to introduce myself. This is my first time here with this group, but my name is Lily. I'm at Parker's New Vision in San Antonio, and I had an interesting experience in which the LAL was thrusted upon me as a resident 3 years ago. So I was able to take it on, and I'm excited to come to the next ones. And I don't know if y'all already talked about this stuff, but I could count on my hand the number of normal patients, like normal cornea patients, we do this lens on. So I would be really intrigued in the future to talk with y'all and pick y'all's brains about like your post-refractive and your RKs and your cones and all that stuff. So
sure. Yeah. We'll probably do, I think we'll do another one early in the new year. RxSight has expressed interest in this forum and, specifically the OD guided discussion. So they want us to keep doing these. And we have the ability to talk off label, and post RK, post LASIK, post, keratoconus patients. So I'm thinking January, February, we'll probably do another one. And yeah, in the meantime, I mean, anybody here, if you want to just email us, go ahead. We're all learning from each other. So there's, I think, plenty of knowledge to go around. But yeah, thanks for spending the evening with us, guys. And that's all I've got. We'll talk
Just
soon.
one last comment, Nick, because
Yeah.
unless I missed it, just for the newcomers, I know we've kind of alluded to it, but this is not sponsored by RxSight. So
Right.
I think that's important to understand that.
Yes. Yeah, this is definitely not sponsored. This is our own thing. So, but yeah, we'll talk soon, guys. Awesome.